A single bite, a single virus. In the 14th century, it unleashed a storm that terrified the world, a disease so feared its very name meant madness. From medieval Europe to modern America, rabies has haunted humans for centuries. But behind the myth lies science, a tiny virus that rewrote how medicine understands infection, immunity, and prevention. Today, despite effective vaccines, rabies still kills tens of thousands every year worldwide. This is the story of one of humanity's oldest and most misunderstood diseases, a reminder that in biology, silence can be deadly. For much of history, rabies was pure horror. Ancient Greek physicians called it lyssa, meaning frenzy. People believed it was a curse, passed by dogs driven mad. Victims suffered convulsions, fear of water, and a descent into confusion that no healer could stop. Throughout the Middle Ages, entire towns panicked at a single rabid dog. Superstition ruled, branding irons, herbs, isolation, none of it worked. Then, in 1885, hope appeared in a Paris laboratory. Louis Pasteur and Émile Roux tested an experimental vaccine on a young boy bitten by a rabid animal. The boy survived. That success proved prevention could defeat a disease long thought supernatural and marked the dawn of modern immunization. Pasteur's discovery did more than save lives. It changed medicine. Before rabies, few believed an infection could so precisely target the mind and nerves. Rabies blurred the line between neurology and infectious disease. It forced medicine to see the brain not as untouchable, but as tissue that a virus could invade. That insight helped shape how we think about encephalitis and other viral diseases. In a real sense, rabies taught humanity how to fight an invisible enemy. Rabies is caused by a bullet-shaped RNA virus in the Lyssavirus genus, family Rhabdoviridae. After an exposure, usually a bite, the virus in saliva enters tissue and binds at the neuromuscular junction, then travels within peripheral nerves. It moves silently, retrograde along axons toward the spinal cord and brain. The incubation period is typically 1 to 3 months, but can be shorter or extend toward a year, influenced by the site of the bite and the viral load. During this phase, the person often feels completely well. No fever, no pain, just silence. When the virus reaches the brain, the storm begins. Early symptoms are nonspecific: fever, malaise, headache, and tingling or burning at the wound site. Then the nervous system signs escalate. 2 clinical patterns are recognized. Furious rabies, the classic form, brings agitation, anxiety, hallucinations, and painful spasms of the throat that can be triggered by attempts to drink water, the infamous hydrophobia. Paralytic rabies, the quieter form, starts with weakness spreading from the bite site, progressing to flaccid paralysis, coma, and death. Once symptoms begin, survival is exceptionally rare. Rabies remains virtually 100% fatal after clinical onset, which is why prevention before symptoms is everything. Rabies today is not a relic of the past. Globally, it causes on the order of 59,000 deaths each year, the vast majority in Africa and Asia, often in children exposed to unvaccinated dogs. In the United States, human deaths are now rare, fewer than 10 per year, thanks to vaccination of pets, wildlife control, and access to medical care. But the virus persists in wildlife. Most animal cases occur in bats, raccoons, skunks, and foxes, and these species account for the great majority of rabies detections each year. Every year, about 100,000 people in the U.S. receive post-exposure care after potential contact with a rabid or suspect animal. The risk is uncommon, but it is real, and vigilance prevents tragedy. What should you do after a potential exposure? First, immediate wound care. Wash the wound thoroughly with soap and running water for 15 minutes. That simple step reduces the amount of virus in the tissue. Second, seek medical care promptly. Post-exposure prophylaxis, PEP, includes human rabies immune globulin for people who have never been vaccinated, infiltrated into and around the wound when feasible, plus a series of rabies vaccinations. The standard schedule for immunocompetent people is doses on days 0, 3, 7, and 14. People with immune compromise receive an additional dose on day 28, and antibody testing may be advised to confirm response. When started promptly and completed, PP is nearly 100% effective at preventing disease. Delay can be fatal. Modern vaccines are inactivated, not live. Pre-exposure vaccination is recommended for higher risk groups such as veterinarians, certain laboratory workers, wildlife professionals, and some travelers to areas where dog-mediated rabies is common. Elimination is a public health goal. International and national agencies emphasize mass dog vaccination, rapid access to human PEP, surveillance, and education as the pillars of control. In the U.S., coordinated animal vaccination and wildlife management have eliminated the dog-maintained rabies virus variant and shifted the risk to wildlife reservoirs. Continued vigilance keeps human cases rare. Rabies hides in silence, then strikes without mercy. It has no cure once symptoms begin, but it is entirely preventable. From Pasteur's first vaccine to modern post-exposure protocols, one truth endures: awareness saves lives. If an animal bites you, any animal, treat it as an emergency. Wash the wound. Seek care. Act immediately. Rabies may sleep quietly, but once it wakes, it never forgives. Follow us for evidence-based public health education, because prevention starts with knowledge. This video is for educational purposes only and does not replace medical advice. For any exposure or vaccination questions, consult a licensed healthcare provider.